And in pain relief and anesthesia, most of the times neuraxial analgesia we give, labor epidurals and spinals. And for LSS patients, we do give abdominal plain blocks and general anesthesia. And pre-assessment and planning, definitely whoever are posted in that OT, personally I discuss with them if any emergency case is being taken. Most of the times I am worried about the platelet counts, BP, and also the patient hydration status. Most of the times what happens is, one side patient may be taking proper amount of liquids and water, but because of strain and also because of the early labor, may be getting dehydrated, or eclamptic conditions or pre-eclamptic conditions. We need to assess, and then planning of the anesthesia. Suppose patient is on anticoagulants, might have taken in the morning and coming for ER within 2 hours or 3 hours, better not to give regional anesthesia. Better to give general anesthesia under supervision. And if any hemodynamically unstable patient comes to the ER, we go there and then we see the patient, and then we start whatever the required vasopressors are there are required. And if needed, the prior intimation will be given to our critical care team either by phone or either by WhatsApp. So and so patient will be taking up for LSS, definitely will come for ICU care, so that they will get prepared what can happen next 1 or 2 days. And postpartum hemorrhage, we had a lot of experience here, and also referred from outside also cases, and respiratory support. And also one of those cases, patient developed respiratory distress after the surgery. I am going to discuss about that. And collaboration and education. If any emergency LSS comes, the anesthetist is going to coordinate with all the departments whichever department is service is required, including blood bank and educating the staff regarding BLS and then ACLS, and also educating the colleagues how to deal with emergency sections. And specific considerations, most of the times common high-risk pregnancies, hypertension, cardiac diseases like mitral stenosis or regurgitations or myxomas or aortic diseases associated with Marfan syndromes, and peripartum cardiomyopathy or stress cardiomyopathy. 1 or 2 days patient may be normal, or third day patient may be having breathlessness and then palpitations. And then when we start evaluating the patient might have had low ejection fractions with stress cardiomyopathy, HELP syndrome, coagulation disorders, antepartum hemorrhage, and placental disorders, and followed by the fetal monitoring. There is DIP 1, DIP 2, every anesthetist they should know, and if they are recurring, definitely they should help the obstetrician to go for a emergency section. Actually, this is the first case what Kola sir actually presented, and he brought the case all the way from the other center to here. Almost he resuscitated very nicely this case. 35 or 38-year-old hypothyroid, G4P2L2A2, 36 weeks of gestation. Actually, this case is different actually. Normal vaginal delivery, developed atonic PPH, and they have shifted here. We did a laparotomy, and bilateral uterine artery ligation was done, and subtotal hysterectomy was done. The same case, yeah. Pressure parking was done, with the MOPS, and under general anesthesia with invasive monitoring we did. And one good thing is here is, being a tertiary care hospital, we do monitor wherever necessary all the invasive monitoring, and we do subject the patient whatever the investigations required. And appropriate blood and blood products transfusion was done. And again, exploratory laparotomy was done on the second POD. All these 2 days, interventional radiologist and then ICU people, they got stabilized the patient. MOPS were removed and patient extubated and got discharged on 7th day of admission. And case 2, 31-year-old with G2P1L1 with 32 weeks gestation, presented with breathlessness. Incidental finding was left atrial myxoma, and immediately CTVS consultation was taken and advised to take up for emergency LSS because that myxoma is giving problem to the patient, and then patient has become symptomatic. And we did this case under spinal anesthesia, regular spinal anesthesia, as myxoma is not obstructing the mitral valve. And on the second POD, we took up the patient for cardiac surgery, went on to the pump, and myxoma excision was done, and patient was shifted to ICU in a stable condition, and patient was extubated on the same day, and patient got discharged on 9th POD, that is 7th POD of myxoma excision. And one more case, 29-year-old, 32 weeks of gestation, severe preeclampsia, gestational diabetes on insulin, intrahepatic cholestasis of pregnancy was there, and gestational hypertension was there, which was not under control, and deranged LFTs and raised coagulation profile was there. Emergency LSAs was done under general anesthesia with invasive monitoring, and observed in ICU for 24 hours, and multidisciplinary team approach was taken for this, because like neurology consultation, because patient had some past history of seizures, and also cardiologist was involved in managing the hypertension, and patient got discharged on second POD. This appears to be a very simple case, but till the patient has got discharged, there was a lot of pressure from the family, and also we were thinking in the other ways, but nothing went wrong, and patient got discharged nicely in this case.